Welcome everyone to today's After Pharmacist live stream, which is a diabetes special. So evening to those that are in the UK and Europe, afternoon and morning to those over in the US, and well done to anybody that's in Australia or New Zealand because it's probably middle of the night over there. I'm just going to do some hellos. It looks like I've already got quite a few people on. So hello to Demi, Mr. Angela, Neil Keita, Laurie. Excellent. Kay Marie. Brilliant. And Sam. Hi. So welcome everybody. I've already had some questions asked previously, and it looks like there's already some questions in the chat already, so I will do my best to work my way through them. There is just so many potential issues and topics to cover with diabetes. I've got a few written down. So you've got what the difference is between the type 1 and 2, and is there this type 1.5? Can you reverse type 2 diabetes? Insulins for both type 1, which is its main therapy, and then for type 2s, and even sort of the new insulin pumps and actual sort of like AI pancreas, and the testing strips and the continuous monitoring devices that you can have put on your arm. And there's all of that before we even actually move on to the medication. And then there's the old medication like the metformin and glyphosate, the new agents such as the flozins, gliptins, and glitazones, and then the injections that everybody knows about, the GLP-1s that also seem to have disappeared supply problems because they're all in the weight loss sector. And then if we ever get there, all the supplements that also claim to help you with your diabetes. So there is just so much. So I am going to rely on the questions that have been asked, and depending on how long people want to stay on for, I'll cover as much as I can, and we can always do a part 2, part 3, part 4 in the future. So I am just going to play my disclaimers. So obviously the information I provide is for educational and entertainment purposes only. Don't take it as actual individual medical advice. Always talk through your individual situation with your own healthcare provider. But if I provide you with something which makes you think, write down your notes and then go and talk to your own healthcare provider. Obviously, I am UK based. I do know that there's differences over in the US, especially when it comes to the cost of such things, and we'll talk about that in a bit. But hopefully we'll move on. I'm just also going to play my intro. Obviously, my aim in the future is to become monetized. So if you can subscribe, like, comment, share, I would really appreciate it. I'm nearly halfway there. I'm at 482 subscribers. So obviously the tag is 1,000. And then for watch hours, currently I'm nowhere near there yet. It's 4,000 hours of watch time because I don't think I've actually built up enough videos yet. And I did upload a new video this last couple of weeks on fulvic acid, and it got really good views as normal. But unfortunately, it was my shortest video so far, only 10 minutes. And so although more people actually watched more of it, it really didn't get me any watch hours. It got me about 4 hours of watch hours so far because, it's only 10 minutes long. So, but yeah, make sure that you go and have a look at all my actual videos on my channel. Have a look at those and any of my previous live streams. Looks like the comments are coming in thick and fast. Hi, Julie. Hi, Natasha. Excellent. So I'm going to start with the first question that I got actually on the community tab of my channel, which is always useful to check out there to keep up to date on what I'm planning to do. And that was, does this type 1.5, this LADA, LADA type of diabetes actually exists. So to explain that, I'll have to explain what type 1 and type 2 is first, just so that you all got that basic understanding. I know some of you will have a gooder understanding than others, but I'm just going to start off and explain it all, and that way everybody's on the same page. So type 1 is usually happens in children, and it's an autoimmune condition because it's actually your body's immune system has gone wrong and it's actually killed the cells in the pancreas that make insulin, and kills off your pancreas so that you can't make any actual insulin. So it usually comes on very rapidly, and the child then, can't, every time they consume sugar, the sugar goes high because they can't produce any insulin to fetch the sugar levels back low. They quite get severely ill, massive thirst, massive dehydration from your large urine output because the high concentration of sugar in the blood, the body tries to kick it out via the kidneys. They end up with something known as ketoacidosis, where the body's trying to counteract the high glucose and the fat levels and modify it all, and it just can't, and it ends up with acidic blood, which is with ketones, ketoacidosis. It's a medical emergency, and there is only one treatment, and that is to actually externally give the insulin back. And there is no other cure for it other than providing the insulin back and finding a regime of giving that insulin back. And so it is autoimmune, not that, and it can be triggered by a viral infection or another sort of illness that sort of, sends the body into that autoimmune phase. There has been an increase in type 1 diabetes, even in adults post-COVID. COVID actually was a trigger for causing diabetes. And historically, even back before we actually even had insulin, type 1 diabetes was triggered by previous plagues and pandemics. But obviously back then they couldn't then treat it. But it is very interesting to see that there is spikes after whenever there's a high viral infection that goes worldwide. There can be the spike of type 1 diabetes that follow. And yeah, it can, type 1, although it mainly happens in children, it can happen in teenagers and it can happen in adults. Type 2 is a totally different kettle of fish, as in it's more that the pancreas slows down, or it can't produce enough insulin for what the body requires. And the reason why that can be is because it could be because the body has something which is like a metabolic syndrome, which basically means that your body is requiring more and more insulin to have the same effect that it used to. And this can be especially true to people who have got a higher body fat percentage. The higher the body fat percentage, the more insulin is required to help maintain blood sugars and keep them low, which is why that, yes, the more obese a population, the more type 2 diabetes that there is in that population. However, for an individual, that doesn't always make definite. Some people can be obese, they can be severely obese for a long time and they never get type 2 diabetes. And you can have people that are of normal weight and develop type 2 diabetes, because there is also other factors, and family history can be a big factor, genetics. So you can have the genetics to predispose you to type 2 diabetes, and even if you keep it a healthy weight, you're still predisposed to getting type 2 diabetes. Now, this also comes in line with, there is what's known as gestational diabetes, which is the diabetes of pregnancy. And usually most people that get gestational diabetes of pregnancy, because of the larger body volume that they're having to deal with having the whole baby, amniotic fluid, the placenta, the blood flow there, it can then affect the person that's got gestational diabetes. It is known that people with gestational diabetes have a higher risk of getting type 2 diabetes later on in life, because they've obviously got that genetic predisposition to having that insulin resistance and getting that. So yeah. I don't know whether the gestational diabetes itself has an impact on the baby, but the child probably will be at higher risk because they will have the genetics of the mother who is at higher risk of having type 2 diabetes. So yes, there will be some sort of link there. The main risk with gestational diabetes is if it goes undiagnosed, the high sugar levels can impede on the sort of the capillaries that are feeding the placenta and can cause problems with the growth of the baby. And actually, it's usually the fact that you can end up with the baby growing too big, which can be problematic. So it is something that all pregnant women do get tested for. So then that's type 1, type 2. Now there is this type 1.5, which is it's sort of latent adult diabetes, and it's actually probably type 1 that gets misdiagnosed as type 2 to start with. So the majority of people with this ladder diabetes, they present slowly. So they go to their healthcare provider with all the sort of symptoms of the thirst, the frequent urination, tired, losing weight and everything. But it's slower than what they would normally have with the sudden onset type 1 in children, but a lot quicker than the normal type 2. They usually have people of also of average weight in normal range. And really, it is autoimmune. So when they do actually go to do the blood test, most of these patients do actually have the sort of the antibodies that are actually killing off the cells in the pancreas that make the insulin. So it is basically just an adult onset, slow onset, type 1 that sometimes gets misdiagnosed as type 2 to start with, but usually if you start the oral therapy for it, it doesn't keep them controlled and they end up onto insulin straight away. So in theory, they ought to then stop the majority of the oral therapy and just go straight onto the insulin, because with type 1, insulin is the only solution. And the other oral medications don't really do much to help it along, because there is no nothing in the pancreas to help produce the insulin, and there is no insulin resistance in the rest of the body that needs looking at. So hope that sort of explains that. If anybody actually has any questions on that, let me know. So no spleen. Yeah, I don't think the having no spleen affects the pancreas all that much. I think it more affects the immune system in other ways. Hello, Mum and Dad. Nice to see you. I think I've said hello to everybody. So, yeah, so pre-diabetes. Pre-diabetes, it only happens in type 2. So type 1, you either, so if it comes on, you've got it pre-diabetic. So this is when you've had your bloods taken and the HbA1c, it seems to have been, it's raised above normal, but is not yet at the threshold where the treatment for diabetes kicks in. So in the UK, it's usually in the range of between 42 and 48 is classed as pre-diabetes. I ought to actually explain the HbA1c which is used. So the HB for the HbA1c, the HB is the hemoglobin, which is your red blood cells. So your red blood cells travel around your body and you produce a fresh lot every 3 to 6 months. So every 3 to 6 months, you've replenished all your red blood cells. And as your red blood cells are going around your body, if you've got high sugar levels, the sugar hitches a ride on the red blood cells. So the HbA1c is actually measuring how much glucose has actually added itself to the red blood cells. And it actually gives an average value of what your blood sugar has been over the last 3 to 6 months. And that's why it's so much more useful than just the random blood glucose test, because the blood glucose test just gives you 1 minute in time, which can be totally different depending on whether you've just, whether you're 30 minutes post a very sugary meal or you've been fasting overnight. So the HbA1c gives an average over the last 3 to 6 months. It's also very good helping with finding out compliance to sort of a diet, compliance to medication, because it's showing the average over the last 3 to 6 months. So it stops which used to be very common. People used to sort of just try and carry on as normal, and then the week or two before the blood test, they would try and behave to get the sugar levels normal for the blood test. That doesn't work with the HbA1c. It is the average over the last 3 to 6 months, which is why even when you've had a change in regime, you do need to wait 3 to 6 months to repeat that to know whether the change in medication has actually done any altering, or your change in your diet has actually done any altering to your HbA1c. So, but yes, pre-diabetes. Now, this is where a lot of the reversal type 2 diabetes can come in. So if you're pre-diabetes or just gone into the diabetes range, and you are slightly overweight or obese, and you have got a sort of high sugar laden diet or a high fat laden diet, then there is the chance that can help reverse it and delay. Now, you don't actually ever cure yourself of type 2 diabetes, because if type 2 diabetes is shown, or pre-diabetes is shown, it shows that your body does have a predisposition to having the metabolic syndrome of diabetes. All you're doing is making sure that you're doing your best to maintain it and reduce the levels with your own diet and lifestyle. Not necessarily the alcoholism, because alcoholism would affect the liver, and although then deranged liver function isn't very good for the body as a whole, it doesn't actually affect the pancreas or insulin resistance. However, somebody that is drinking a lot of alcohol, they have there is the problem that alcohol itself is actually a sugar. Well, it's related to the sugar molecule, and it actually changes. So alcohol is counted as sort of 7 kilocalories per gram, whereas sugar's 4 and fat is 8. So it is a high calorie alcohol, plus a lot of alcoholic drinks come with a lot of sugar. Not so much your sort of plain spirits, but some of your sweetest spirits, your beer, ciders, wines, they come with sugar content. The other thing with alcohol is that alcohol messes with your sugar levels, as in you'll get a spike as you're having the drink and the alcohol's in your system and the sugar's in your system, and that both raises it. But then alcohol, as you metabolize the alcohol over the next few hours, it can actually cause your body to go too low on its sugar. It sends the metabolism the other way, and you can have a hypo. And this is a very big problem with teenagers who have had type 1 diabetes. They've got it, quite often with their parents' help. They've controlled it very well through their childhood. They then find alcohol as a teenager. They also don't want their parents mollycoddling them with their levels all the time, and they'll find that they'll go out for a night out, they'll have the drinks, the sugar levels are raised, they'll think that they need the insulin, but then at 3 or 4 o'clock in the morning, they can end up with a hypo and even go into a coma and even die. If you know of any teenagers with type 1 diabetes, if they could be on continuous glucose monitoring overnight, that's great, and never leave them alone overnight. They might not be like being mollycoddled, but they probably need to be. So let me just go back. We've got a lot of you on then here, so. Yeah. So there is the thing. It can be difficult with charting patients in on the computer system, and this is the problem that we found is that sometimes the coding on computer systems, sometimes they're just coded as just diabetes, neither one or two, or they've been coded with type 1 or type 2 or both. And historically, depending on the sort of qualifications who have actually put the read codes in, it has varied. So at one point, when a type 2 diabetic patient was ending up on insulin, people were seeing the insulin and coding them as type 1, whereas they're not. They're just type 2 that have got as far down the medication line that they've ended up on insulin, but they're not type 1. So, yes, Laurie, I'll try and do that. I will try and, yeah, so I was just asked, can I read the questions aloud so that if people are just listening, the response makes sense? Yes, I have to remember that although it's very useful for me to put the prompt on the screen, some of you are busy running around doing other things and have this on, just on for listening. Right, I'm going to go back up to the beginning of the chat. Right. So then maybe before the stream asked, said it might be a heated question, but the cost of insulin for diabetics in the US is inhumanely high, and too many people die from being unable to afford it. Is it more attainable in the UK? Well, luckily, yes. In the UK, if somebody requires insulin, because the type 1 or they've got that far down the type 2 therapy lines, insulin is free on prescription on the NHS, which is very lucky. However, the NHS spend on diabetes is skyrocketing, and it is a real big cost pressure for the NHS to spend on all diabetes medication, including insulin, and including the fact that the manufacturers for insulin are continually, we're having stock shortages, we had the problem where certain pens weren't available, and we've had to change people onto the pen, the reusable pen with the cartridge that go in, which not everybody can has the dexterity to be able to change the cartridges in them, and they do need it as a disposable pen. So there is the issue of that. Now I'm going to see if I can share, because I did have a quick look at the pricing in the UK. So if I Microsoft Edge that. I'm not quite sure why it's not letting me share. It's not letting me share the screen. There we go. So this is openprescribing.net, and this is a public website and it shows all the prescribing of prescriptions that were dispensed at community pharmacies in England. And you can go down and do analysis down to individual drugs, to actual the individual preparation, so the actual tablet and strength or the liquid, and you can go right down to GP practice. But I'm just going to look at the overview. So when we look at the spend, the total spend across all practices in England, as you can see, the cost is continually increasing. This is from January 2019 to up to January this year. So it's, the data is up to date by about 2 to 3 months. So fairly up to date. And whereas back pre-pandemic, we were spending £78 million a month on all drugs to do with diabetes, it is now up at 114 million pounds every month being spent on drugs to treat diabetes, which is a crazy amount of money that the NHS is having to spend. Luckily, people with diabetes do get free prescriptions. I did have a quick look at the breakdown for insulin and calculated. So insulin's fairly stable because the amount of people of any one time that are type 1 diabetic is staying fairly stationary. And type 2 diabetes is getting more, we're getting more and more people being able to be controlled with the newer agents that are either tablets or injections, but non-insulin, which is great because unfortunately type 2 diabetes, once you're on insulin, insulin itself can cause weight gain, which can be a vicious cycle in deterioration in type 2. So the longer we can keep type 2 off insulin, the better. But as you can see here, we're spending about £30 million a month on insulin across the whole of England each year, well, each month. And I did do a quick calculation looking at the items, and it looks like the average cost of insulin prescription per item is about £50, which does seem, a decent amount. So for us, the NHS is being charged about £50 per prescription for insulin. I don't know how on earth that compares to what people in other countries are being charged for their insulin on prescription, where you actually have to pay for it. So I'm just going to stop screen sharing. But I looked that up. But yes, it is very, very hard to know sort of which system works better. It does seem good that the NHS can provide free prescriptions to a lot of people, but not everything is covered on the NHS, and some people still end up having to pay for prescriptions, and it does seem unfair which conditions are on prescription for free and which ones aren't. So asthma isn't covered, even though asthma do need to use the preventer inhalers every month. So there is the prepayment certificate for people in the UK where you end up paying £10 a month, which probably works out better than the majority of other countries having just a direct debit of £10 a month to cover all your medication. But then there's the other issues of, is the strain on the NHS of the cost of medications to the NHS, is that added to the fact that not all patients actually appreciate the cost of the medications, and it can lead to sort of over ordering and wastage and people just expecting that they should get things for free because the NHS is free. That's a whole sort of question which has many different arguments for. Yeah, so Natasha, the obesity in the US causes diabetes is on the rise. So yes, there is always the argument of some health conditions could have been prevented if somebody had had access to a healthier lifestyle. Now, whether an individual person, how much that person is to blame for their health is a difficult question, because some people have other chronic illnesses that have been the cause. Some people have just the deprivation of where they live. They just don't actually have access to the education and the healthy foods to eat. There's so many public health factors going into sort of, can you just say somebody's obese, therefore it's their fault that they've got diabetes? It's a lot more complicated than that. There is so many emotional, social, physical reasons of why people end up in the health that they've got. Yeah, so generally, Kay Marie has said, our medical insurance companies generally treat obesity like a cosmetic issue, so refuse to pay for treating it. Now, this is the discussion. I'm going to try and keep off the weight loss discussion and try and just focus on the diabetes. But that is the issue that we do have in the UK of if you're using the GLP-1s to treat diabetes, that is on the NHS. If you have severe obesity and have other comorbid risk factors, then there is the potential that you can get referred into a tier 3 service to get the GLP-1s and other weight loss therapies such as Orlistat on the NHS. But for a lot of people, they are encouraged to go private. Okay. I can go back. So hopefully I have altered Nightbot so that if you do use emojis, Nightbot shouldn't tell you off and put you in timeout. So it is a learning process with Nightbot. So if Nightbot does play up for anybody, let me know. I like that Nikita had said that she was eating ice cream, some dairy-free matcha ice cream. That sounds lovely. And Nail Keita, I'm hoping I'm pronouncing that. Is it Nail Keita? In Canada, insulin and metformin are covered. As a pre-diabetic, the only thing that wasn't covered was the lancet for checking the blood. Yeah. So in the UK on the NHS, if your GP or nurse determine that you should be measuring your blood glucose levels, then the blood glucose testing machine, the strips and the lancets are all on the NHS and are on prescription. However, there are a lot of people that want to check their blood levels when actually there's no medical need for it, and that's not on the NHS. And people can pay privately. Well, they can buy their own machines and they can buy the test strips and lancets off Amazon, which is what we recommend people do because it's the cheapest way. So Nail Keita's also said that since being on Ozempic, she's managed to get off her metformin and been okay. Now that is always the thing with new adding in new medication, is always seeing which is the best out of medication. So a couple of weeks ago, we ran a blood glucose testing swap shop where we invited all our patients in and said, fetching your old glucose testing machines and we'll upgrade you to the new ones that fit in with the new NHS guidance. But while they were there, we actually chatted to them about their medication and gave them a quick medication review. And I did come across somebody who was, they'd be started, it wasn't Ozempic, it was azenatide, one of its sister drugs. And they'd been started on that. They've managed to get their body weight from the obese category through overweight into normal. And she was wondering whether she should come off that. But she was also saying that her insulin usage, which she was testing for blood glucose, she was only needing like 9 units of that a day. So we had the discussion that actually it would be best for her to come off of other medication and stay on the exenatide with benefits that actually has in the long term in protecting her heart, and coming off the insulin, which doesn't actually have any sort of benefits in itself and could trigger the weight gain again. So yeah, it is always there's about 6 different groups of medicines now for type 2 diabetes. So it's always a way of looking at which one is having the most benefit and dropping off any that have got side effects that are too bad, the balance of all of that. So Laurie said, your sister's on Ozempic, and after almost a year, it still makes her so sick she can barely eat at all. Now, that is the problem with the GLP-1s, these injections. I've talked about that. I've done a standalone video on Ozempic, and I have talked about it in the weight loss live stream that I've done. The way that the GLP-1s act is that they act on the process between the hormones from your stomach to your brain, to let you know, the brain know that you're full and how much sugar's in your system and whether you actually need to eat or not. So when you eat while you're on the GLP-1s, it will send your brain to your signal to your brain that you're full earlier, and that actually can lead to some nausea, and it can actually lead to vomiting. And some people really can't cope with the nausea and even the vomiting that could result as a side effect from the GLP-1s. Some people find that actually that's the side effect, helps stop them binge eating, it helps them with their portion control, it helps them regulate how much they're eating, and that's how it helps them lose weight. But yeah, if that is something that somebody's not eating. Now, not eating, although that will lower your sugar levels, you're not going to be getting in enough actual nutrition of protein and vitamins and minerals and fiber and everything else that is needed. So that is something that needs to be discussed, because that's a side effect that might be, although it might help the sugar levels, it might help the weight loss, actual overall health is probably going to deteriorate if they're not getting the other nutrients that they need. And as I think somebody pointed out, some of the medication, and quite a lot of the diabetes medications, you need to start at a low dose and step it up slowly to find out what dose doesn't cause side effects and actually is effective. There's no point jumping straight in at a high dose, can cause too many changes too quickly, sudden drops in sugar levels aren't appropriate, and sudden amounts of side effects. And Nell Peter said, I'm assuming she's mentioning the GLP-1s. I was without it for a month because of dumb celebrities making it popular, so couldn't get it. So when I was sick, when I got back on it, yeah. So yeah, so if somebody's been titrated up to the higher dose, there's been a stock problem, they've come off it for a month, and then suddenly restarting back to that higher dose can mean you're suddenly getting all those side effects yet again. And yeah, unfortunately, there is more money in the private sector for the drug companies to sell to the private sector than for them to sell to the NHS, who want it at a discounted price. There's still supply problems with all of the GLP-1s, except for the very, very new GLP-1. Right, I'm just going to share this. So try and put this. Yeah, so I have wrote sort of a list of all the different types of diabetes treatment, just so that we can know what we're talking about, and you can think. So when we're talking about the GLP-1s, it's the semaglutide and the ozempic. And there has been a brand new one that's come on the market, which is a GLP-1 plus a GIP. And it affects two hormones that affect the satiety and the blood and the signals between the stomach, the blood sugar, and the brain. And whereas the other ones can cause about sort of 12 to 14% weight loss, these ones can cause maybe 16 to 18% weight loss. So currently there is supplies of these, but it is more expensive, and it does look like the private sector are already selling them. So Mr. Ranger Lab asks, in your opinion, what are some of the most common myths that you hear concerning diabetes? The two that really grate me is using chromium supplements and apple cider vinegar to cure your type 2 diabetes. They can't cure your type 2 diabetes. There is quite a lot of different supplements and herbal remedies and such that can affect your blood sugar levels. And chromium is essential in making the insulin molecule. Like you need iron for your hemoglobin molecule enzyme protein. So making a hemoglobin protein, you do need iron. It's the same with making the insulin protein. You need a chromium molecule in there. You only need in very small amounts. It's only a micronutrient. Hardly anybody is actually deficient in chromium. And even if you do whack in large doses of chromium, it isn't going to make your pancreas make any more insulin. It's not going to change that. So if somebody truly was chromium deficient, then maybe it might help. But it ain't going to repair your pancreas, and it isn't going to help if you've got insulin resistance, and it isn't going to make any more insulin. So it's totally pointless in type 1 because you can't even make any chromium, you can't even make any insulin. And in type 2, it's unlikely. And yes, apple cider vinegar, it does seem to show that you can actually, it does lower your blood sugars a little bit. But in the trials, they weren't quite sure whether that was because people had nausea while taking it, and so they didn't actually take in as much sugar in the diet. But you might as well just eat something pickled. And obviously, you've got your pickled things that are good for your gut microbiome, like kimchi. So I would do that rather than take an apple cider vinegar supplement. Okay, so I've got people that are talking about the pets, which is great. I've answered the alcoholism. Right, I've got Neil Peter. Does blood pressure have an effect on it and diagnosis, specifically very low? Right, so when somebody is diagnosed with type 2 diabetes, they will get a full health screen because it has been shown that type 2 diabetes is more of a metabolic disorder and increases the risk of cardiovascular disease and stroke and other complications, kidney disease and such like going forward. And there is information showing that for diabetes, having high blood pressure actually causes more complications for people with type 2 diabetes than the actual high sugar levels. And if you've got somebody with type 2 diabetes, it's actually more important to control the high blood pressure than it is to control the high blood sugar levels, because it's the high blood pressure that's pushing the sugar around the body that can actually be causing the more damage. When it comes to being specifically very low blood pressure, I don't know of anything with the links of very low blood pressure affecting diabetes, although I would say having both in normal range is going to be better. But yeah, so ensuring, so you'll probably find that people who get diagnosed with type 2 diabetes, especially if they're over 40, they will get a full screening. If their cholesterol is high, they will be offered a statin. They've even found that even just having type 2 diabetes, no matter what your cholesterol level is, there's a good chance that having a statin will actually lower the risk of cardiovascular disease going forward. So even if the cholesterol isn't that high, you may still be offered a statin. And then the blood pressure, getting the blood pressure under control. And the best agent for treating somebody with high blood pressure who has also got diabetes is using an ACE inhibitor, which is one of the ones ending in pril, ramipril, enalapril, any of the prils, because that actually has a protective effect on the kidneys in somebody that's got type 2 diabetes. Yeah, so Kay Marie says, it drives me nuts when people say lifestyle cures diabetes. It manages it, but it doesn't make you non-diabetic. Exactly. It might help you keep your sugar levels in normal range alongside other modifications, but no, it can't cure it. And again, just carried on to say, morbidly obese and high carb diet, sadly. My brain's hating me, my immune system thinking I'm a pathogen to myself. Hyperbole for lupus and potatoes being delicious. Potatoes actually aren't the worst thing. Yes, they are sort of high in carbs, but depending on how you eat them, if you eat them with other foods that have got a high fiber content, alongside stuff that's got protein in it, even alongside things with some fat, it can actually slow the digestion of the carbs in your potatoes. So having, jacket potato with tuna, which has got your protein. The jacket's got some fibre in it. Maybe have something else alongside it. Add some sweet corn in there for the fibre. You can still enjoy your potatoes. Just yeah. Kay Marie said regular medication reviews is always a good idea for diabetics and other chronic conditions. Yes, so you should be, as a minimum, having a yearly review with either your GP or your nurse, and even the pharmacist, if there's a pharmacist at your practice, and sometimes moving that up to 6 monthly. And there's a whole load of checks once you've got type 2 diabetes that need to be done, including they should be checking your feet. And this is one of the 8 checks that is always getting forgotten, is checking your feet. Because your feet can show the first signs of whether there's actually been any damage. So they should be checking your feet to check the temperature, the blood flow, and the feeling in your feet. So if they're not asking for you to take shoes and socks off in a review, you need to be asking, am I having my full diabetes review? Oh, hello, Lynn. I don't think I've already said hello to you. So, friend with diabetes 1 is pregnant. Is there anything I should look out for just to keep her safe when I'm around her? I'm already her second alerted for when a pump makes a sound. Well, that's excellent, that she's got people for alerting. So when somebody has type 1 diabetes and then they get pregnant, they should make sure that they're upgraded to having the best continuous monitoring possible. And there will be changes in their insulin requirements and their food requirements during the pregnancy. You don't need to eat for 2 during pregnancy, but you do need to eat for sort of like 1.2, especially in the second and third trimester. And the insulin requirements are increased because of the increased sort of body load, body weight, feeding the placenta. So it's just helping her because, and also the other thing is it might change because of all the other hormones going around in her body. What she normally feels when she's going low or going high may be different. So she needs to make sure that she checks her levels. Now, this is one thing I was going to say for type 1 diabetes now, they are really trying to move the majority of people with type 1 diabetes from having to do test strips, 6, 7 times a day, sort of pre-meal, post-meal, morning, bedtime, to actually moving most of them onto continuous monitoring, which are the devices that go on your arm. Now, there's a circular one, which is the Libre. That's usually for people with type 2 diabetes. And then there's the Dexcom, which is more of a sort of squidged oval shape. So it's larger at one side than the other. And that's used. And some of the, I think it's the Dexcom 5. Dexcom 5 can actually talk to an insulin pump that somebody has, and you can actually have a closed loop system, which basically is like a pancreas, your own pancreas, where your sensor on your arm is checking your blood sugar levels continuously, literally every 5 minutes, and it's got a trend of whether it's going up or whether it's going down. And it sends a message to the insulin pump, which is continually putting in a very low dose of insulin, and it can either increase that or decrease that depending on whether the sugar levels on the device is going up. It's absolutely amazing, but it's not foolproof. Somebody can alter their sugar levels too quickly for the system to react. So if it was down a really, really sugary drink, then it would be too much for the system to cope with. And if they, alternatively, if they were going to suddenly do a massive amount of exercise, they could lower their sugar levels too quickly for it to be able to alter. Because the one thing that you can never do is take insulin out of your system. So if you suddenly do a lot of exercise and send your blood sugars low, you can't take insulin out of the system. You have to put sugar back in. So, but no, these systems are getting better. Plus, now with type 2 diabetes, if with the type 2 diabetes, you're on any of the medicines that actually can cause you to go hypo, which is the old glycoside and flozins, or you're on insulin and you need to alter the insulin dose, then you need to test your blood sugar levels. And some people, it's type 2 diabetes, if they're requiring to do their blood sugar levels more than sort of 4 or 5 times a day, or they can't seem to get them in range, then they can actually have a trial of the round Libre continuous device to actually see what's happening in between and how to alter the dosage. So I'm hoping that explains that. I'm just going to see if there's any. Yeah, so Lynn said she has a continuous monitor that makes sounds every time she goes above or below the desired levels, and I check on her every time I hear the beeping. Yeah, so there is that. You can actually have it sent to people's phones. So I know of a teenager who has type 1 diabetes, and the device actually sends the signal to her mum's phone. So even while she's at school, her mum's phone will actually trigger and let her know if the sugar level's going too high or too low. So it can be sent to multiple people as well. So it doesn't have to just be one person. It can be 2 or 3. So the technology is getting great. However, it is technology, and unfortunately, it can fail. And one of the big problems that we've had is that when phones update, sometimes they update and then the app for the device doesn't always work on the phone. And there's and then there's a sudden problem, especially if that's required to talk to the insulin pump and then it doesn't work. So there is backup devices that the companies that can send out, but a lot of people don't like having a separate device for that as well as their phone. They prefer it all on the phone. So I've got a message from Sally. So hello, Sally. I think you're new. I've not seen your name before, so welcome to my live stream, and hopefully I can answer your question for you. So if I'm taking metformin, when is the best time of day to take my dosage? Right, so metformin comes in 2 different forms. So there's a normal release metformin and there's a modified release metformin. And the normal release, normally on that dose, they try and encourage you up to taking it 3 times a day with your 3 main meals, just before your 3 main meals. If you're on the modified release, then it's best to take it 1 with your breakfast, and if you're only on the dose of 1, so that 1 with your breakfast should cover you for all the day. They do want you to take it twice a day. It's usually once with your breakfast and once with your evening meal. Now, the really good thing about metformin is that metformin, although it lowers your blood sugars, and so it can help stop those spikes, the way that it lowers your blood sugars, it can't send it too low. It only gets rid of excess sugar, and it only sort of moves the excess sugar into the correct parts of your body. It can't actually lower you to having a hypo. So you have no risk when taking metformin of ever having a hypo. So even if you were to take it at the wrong time of day and you don't eat a meal, there is no way that it can send your blood sugars too low. So there isn't a dangerous time to take it because it can't send your blood sugars too low. But the best time to take it is before each of the main meals. So Kay V has asked, I know biotin can affect blood labs like those done for diabetics. Are there any other supplements that can muck around with blood sugar measurements? I'm just trying to think for sugar levels. So yeah, biotin is definitely bad for thyroid. Biotin. Just creatine is really bad. It can affect your kidney functions because it does affect your creatinine. Although creatine and creatinine are different, they are metabolized along the same pathway. So taking creatine supplements and protein supplements can actually affect your kidney function. When it comes to blood sugar measurements, I would say the only ones I can actually think of would be is if you were taking illegal supplements of testosterone and anabolic steroids, because they totally mess up your sugar levels. And also if you're taking any supplements that have got sugar added to them, because a lot of these supplements that you have, they actually do have, especially like the bodybuilding products and things, they can actually have a lot of their own sugar levels in them, and they quite often hide them under other names, so you don't always know that it is glucose. But I could actually have a look into that. That would be an interesting one to actually do. Things, supplements that affect lab results. That would be a good standalone video to do. Okay, so Sam says, a friend of mine keeps saying they think they have diabetes because they have a thyroid issue that is causing them to pile on weight. Right, so yes, having a low thyroid level can cause weight gain, and I hope that they're actually discussing with their doctor taking their thyroxine supplement or getting help from endocrinology if it isn't just simple hypothyroidism, so that they can actually maintain their weight. It is still the reason why you gain weight with thyroid is because yes, it does lower your metabolism, so it does slow your body down, makes you more fatigued, makes you less likely to do as much, and it also increases your appetite and you want to eat more. But there is still an overriding calorie. You're gaining weight because there is actually a calorie excess. You are eating more than you're expending because your body is sort of going into sort of reserving its sort of expenditure of and trying to eat more. So it can still be reversed with trying to eat a healthy lifestyle and be in a slight calorie deficit. Obviously, not starving themselves, and they could probably do with some extra help because it would be more difficult for them. As for whether the thyroid itself can cause diabetes, no, there is no link there. However, any weight gain will help, will cause a predisposition to type 2 diabetes. And if she is feeling that the weight gain may be sort of affecting her, she should be getting her HbA1cs monitored to see if they are increasing, and then seeing if she needs any help if she does go into the pre-diabetes section. So, I think I've gone through quite a few things. So I'm just going to cover. So you've probably seen on my screen that I have sort of screen shared just a few of the different therapies that are out there at the moment. So the first line, and it still is for type 2 diabetes, is metformin. Although it can be hard for it to be tolerated and needs to be started slow and stepped up because it can cause a lot of GI issues and diarrhea, it is actually still one of the agents that actually has the best outcomes long term for people with type 2 diabetes in reducing their overall mortality, so risk of dying, and reducing their risk of heart attacks and heart disease. So it is still there as sort of the gold standard to start with, if somebody can tolerate it. Obviously, I mentioned earlier there is a modified release version which can help for people who have got who do get sort of stomach upsets and diarrhea. Having it as the modified release can help reduce that and start off slow and step up. And it still is best to keep that in, even at whatever dose that you can tolerate, all the way through adding in any other medications. Now it used to. Oh, so Laura's just said I have to run. Thanks, Eloise, for your knowledge. That's what. Yeah. I'm glad that you all appreciate it. If you do have any other questions, feel free to sort of add them into the comments. I can always do a second or a third or a fourth diabetes special. Although, if everybody can let me know if there's any other subjects that you want me to do. So Sam says, I keep advising them to eat a healthy diet and do some exercise, but they're refusing to change the diet. There's not a lot you can do, Sam, other than, if they've got the information there, they know the information. Just allow them to know where they can go to get help and support. And just encourage them that, just because she's gaining weight doesn't mean it's a definite, end. There is always ways of changing and moving back, losing that weight once she does have the thyroid under control. So I mentioned metformin. Used to be traditionally 15, 20 years ago, even probably 10 years ago, if you couldn't get controlled on metformin, they would throw in glyclazide or glipentlamide or one of the other sulfonylureas. Now, these are really good, as in they do lower your sugar levels, mainly by forcing your pancreas to pump out as much insulin that they can. They are good, but they can actually, because of the way that they act in forcing your pancreas to pump out as much as they can actually speed along the type 2 diabetes in the long run. So people actually sort of, they get to a point where the pancreas really can't produce any more insulin. Also, it doesn't seem to, although it does get the sugar levels down, doesn't seem to be protective in the long term for the long-term outcomes of type 2 diabetes. And there is the risk of it causing hypos. Because it causes your own pancreas to kick out insulin, you can actually get hypos on it, which is normally why when you get started on the glyclazide, especially if you're still driving or such like, you do need to then start blood glucose testing, which with some of the newer agents now, there's a lot less need for type 2 diabetes to be doing blood glucose testing, because with the other newer agents, unlike with metformin, it can't cause hypos. So there's no risk of a hypo. So there's no need to do the blood testing. What you need to be doing is just looking at your overall level of the HbA1c every 3 to 6 months. In fact, they have actually shown that for some people, the overuse of blood glucose testing in type 2 diabetes can actually worsen control and lead to a much higher level of anxiety. So if you think about it, if you don't do any testing, then you're going to just be looking at your diet overall, trying to do your best. You're going to take your medication and try and do your best at that, and just see how you go. But if you're actually testing all the time, when you get a high level, you're going to become anxious and wonder what you can do to alter it. And if you have a low value, you might decide, oh, I've got a low value, I can treat myself, and actually end up consuming more calories every time that you're low, rather than actually making sure that you're consistent and level all the time. So there is for people who are newly type 2 and the lower levels of type 2, they actually are preferring not to do any testing because of the increased risk of anxiety and the increased risk of treating and actually making the control worse. So the glycoside, it is still very useful for those people that maybe need to get their sugar levels down quickly before and then go on to other agents. So if they're sort of late to getting the diagnosis and they should have been diagnosed earlier, or they need to get the sugar levels quickly down because they're awaiting for surgery, and they need to get the sugar levels under control. So there is still a place for it, and it's still there, can be used fourth or fifth line if other agents aren't working. Yeah, so as Kay Marie said, my boss did one of the studies that showed that many people with diabetes do just as well just relying on the A1C. Also, the providers can focus on lifestyle rather than reviewing logs. Exactly. So the the testing is used when people are onto the insulin, and you need to work out what the daily dose of insulin needs to be. But yeah, or to help show when there's hypos. But yeah, just looking at an overall. And the thing is, when you come to thinking about healthy eating, it's not, you don't want to be focusing on individual meals. You want to be focusing on the whole week. Yes, it's okay to eat a few biscuits over the week, but if you were eating 4 or 5 packets of biscuits over the week, then that's a problem. You want to be increasing your fruit and veg over the week. You don't have to have it at every meal. You know, if you prefer just to have fruit between meals, then that's fine. So it's looking at the overall week. And then again, with exercise, it's not about doing sudden bursts of exercise, but just generally increasing up your steps. Little and often is actually better, especially for people who have got other chronic diseases and chronic disabilities and such like. Little and often works so much better. So there's the gliptins. Now, the gliptins are basically the half of the pathway that the GLP-1 injections use. So they do affect the same pathway that is the signals between your stomach, your pancreas, and your brain, and they're acting it, but it's only acting on half the pathway. So they're not as potent as the GLP-1 injections, but they are useful for people that don't want to go on the injections or don't particularly need the weight loss, although they are definitely weight neutral to weight loss. Oh yeah, that's what it need to go back. The metformin also encourages weight loss, but glycoside encourages weight gain, which is one of the reasons why, again, it's gone out of fashion. Because of the way that it forces insulin out the pancreas, it also forces weight gain. But yeah, so the gliptins, they cause a little bit of weight loss. They help with the signal between the stomach and the brain and the pancreas. They don't cause any hypos. So they are they're a tablet version of the half GLP-1. And a lot of people, when there's been these GLP-1 shortages, they've been swapped onto a gliptin to tide them over until they can have the supplies back of the GLP-1s. Now, what needs to make sure, and this is one of the safety searches that I do, is that nobody should be on both a gliptin and a GLP-1 because they both act on the same pathway. So if you're having one of each, you're basically having a double dose, which can take you to a toxic level. And there is the risk from both of them, very, very minute risk of, say, I think it was about 1 in 1,000 risk of pancreatitis. But if you were to have somebody who got both of them at the same time, that risk more than triples because you're really pushing on that same pathway. So Sam says, my friend is also refusing to wear their hearing aids because they say it's embarrassing. They're as deaf as a post without them. Okay. Yeah, I think your friend probably has a lot of issues. They could probably do with having some sort of support worker to talk to help them. I don't know whether sort of they've got anybody that there's a healthcare assistant or somebody at the surgery that could really sort of talk to them. Maybe even um, we have what we call social prescribing, which is getting people into sort of local groups that they can talk to and get support. I would also say maybe getting some support from sort of local charities. Um, there is the thing that, yeah, although, is it because the hearing aids and they say it's embarrassing, or is it because the hearing aids hurt? And that is a big problem. People, is when they're losing the hearing, when they come to wear hearing aids, the actual putting the hearing aids in and then suddenly having everything loud again can actually hurt. And that is actually a physical pain of the overstimulus, sensory overload of that signal now coming in, which can be a reason why many sort of hard of hearing people turn their hearing aids off. It's a very big reason why kids which have been given cochlear implants really struggle having their cochlear implant switched on all the time, and that they need to be able to have space to actually switch it off because it's a device that's on there and it does hurt when it's sending the signals to the brain. It's sending the electrical impulses to the brain. So I think that there does need to sort of be people might sort of struggle with these aids more than people realise. Um, The one of the newest ones on the block is the Flozins. So, they're also known as SGLT2, which is to do with sodium glucose transmission across cells. But these help the body and the kidneys filter out any sugars that are not used and help lower the blood glucose levels by kicking out excess sugar through the kidneys. They also help improve kidney function. So they're actually now using these for people um, with reduced kidney function. They're also using it in heart failure. They've also found that these are really good in helping in heart failure because it helps with kidney function in heart failure. Um, so yeah, so the Flozins are good, except for the downside and risk with Flozins is that they can increase the risk of UTIs, sort of urinary tract infections, and thrush. And also because they are actually can increase the urine output, it can lead to dehydration. So you need to make sure that you're well hydrated with that. All right. So, oh, hello, DC. You've sneaked in. Obviously, everybody says hello to DC because DC is great. She runs her own channel where she debunks crazy MLM companies. So I'm going to see if I can get Nightbot to link her channel. But yeah, if you want any, if you fancy looking at crazy MLM companies coming out with total garbage, watch DC channel. It's always good. She's great at debunking uh, the whole sort of MLM culture of cult like structure that they have, and the pyramid scheme that sort of the FTC shows that 97% of people don't actually make any money. So have a look at DC's channel. Mr. Angel Lab, I have found that the occasional increases in blood glucose testing help to give info on what foods are causing spikes. Now, that is where it can be useful, especially if you're introducing some new foods and you're not quite sure whether where they're at with sort of the glucose content, because it's not just about the glucose content of a food, it's about the whole composition, because even though one food might have 4 grams and another food might have that same 4 grams, if it's paired alongside a decent amount of protein and fiber, then that can actually lower what's known as the glycemic index, so that you're actually slowing how that glucose goes into your body, and it's a much more of a smooth over 1 to 2 hours increase into your bloodstream, rather than a sudden in and out of your system within sort of 15-30 minutes. And if you find a food that causes a spike, you might just want to save that as a treat. Or if you've got a food that you know causes a spike and you want to enjoy it, so if there is a particular sweet treat that you like, and this is probably why for generations we've always done that, have it after a large protein fiber-filled meal. So you have your large protein fiber-filled meal and then have your sweet treat after then, because then it can't cause that spike, because it's got to wait for all that other food in your stomach to digest, and it slows it down. Whereas if you have a sweet treat in between two meals while your stomach is empty, it's going to cause that spike. Now, what I am annoyed at is that there's these companies out there that are selling these continuous glucose monitors to people that are healthy. Now, if you're healthy, it doesn't matter whether you have blood sugar spike, because you have a working pancreas that automatically lowers produces insulin and lowers it. And so, yes, you might have a spike that's up there in the 10, 13s for, 15-20 minutes, but then you're back down again without actually having to use any external medication or insulin. So it doesn't matter. And and there is no link between a healthy person having glucose spikes and their long-term risk of diabetes. The long-term risk of diabetes is more to do with your family history, your genetics, and your overall healthy lifestyle and weight. So, sorry, I'll get off my soapbox about that. But yes, I'm on my soapbox about the supply problems that we have with glucose monitors, as well as the supply problems that we have with GLP-1s, them being overused by healthy people. So I think I have covered quite a lot. It has been all over the place, but I hope I've covered everybody's questions. I'm just going to have a quick look back at the comments, but if anybody can think of any comments that I've missed, or if you've got any other comments, I can stay on for another 10-15 minutes if anybody wants. If you can just ask them in the chat. Double checking. I think I'm getting better at juggling all of this. I think I've covered them all. I can't see any that I've missed. Oh, I've got new comments, so I'm coming back down. Okay, so people saying thank you and bye. Yeah, okay, that's brilliant. So thank you, everybody. If you haven't already seen my video that I've done on fulvic acid, it's there. It's only 10 minutes. So if you watch it on double speed, it's only 5 minutes, but that doesn't give me as much of my watch time. And I'm hoping, I've wrote the script. I'm hoping to record this week a video on proton pump inhibitors, your PPIs, which are your lansoprazole, omeprazole, pantoprazole, and all the risks of taking them long term and when the benefits outweigh the risks. And I'm hoping again to try and keep it at the sort of 10-15 minute mark, because that gets better engagement, even though it doesn't quite get me the watch hours. But once I get more and more videos uploaded, hopefully people will find my channel, watch one and go back and watch older ones. But yeah, thank you everybody. So thank you Rosie, Natasha, Mr. Angel Ab, Mum and Dad, Sam. Seem to have had a few new faces. I think there was a Sally that's a new person. So great to see you all again. Great. Oh, Lynn. Great to see all the usual faces and nice to have new people. But yeah, let me know on my community tab or on comments of any videos if you've got any subjects you'd like me to cover, or send me a DM on Instagram. Oh, Henry, yeah, I'm looking forward to the PPIs. So PPIs is one of my specialties. I have wrote for the NHS. I have wrote some guidelines to help with the de-prescribing of PPIs in people that don't actually need them, because it can be very tricky to stop them, because you get rebound acid and symptoms, which doesn't mean that the original problem's coming back. It's just the getting withdrawal symptoms as such. But great. Thank you everybody for joining me again, and hopefully I'll be on again in 3 weeks. So let me know your subjects that you would like. Oh, yeah, Sam, I was thinking of doing one that was cardiovascular and stroke and such like. So everything to do with sort of like blood pressure, blood thinners and such like for, yeah, for the TIAs, strokes, heart attacks, because it's all the same treatment. It's all making sure that your blood vessels are working to the best. Okay. Bye, Sam, DC, Demi. See you all.